Thank you very much for inviting me. And I will just add that I spend most of my time treating patients rather than doing medico-legal work. I think this is a great meeting. I think it's a very, very good idea, and I've already learned a lot this afternoon about things I thought I knew quite a lot about. We have slightly put the cart before the horse, looking at the effects of the problem rather than the underlying cause. And of course, if we were better at preventing the development of Cauda Equina syndrome or treating it earlier, then a lot of the problems we talked about earlier would be less frequent. So I would like to do something in the future to try to prevent this becoming such a severe complication. And I think Nick Todd is going to talk a bit about that later on. So I'm what they call a spinal orthopedic surgeon. So I train in orthopedics, but now virtually everything I do is spinal. We've now got 8 surgeons, and we treat a population up to 3 million. So that doesn't mean we see all the patients from that population with spinal problems, but with complex problems, we see most of the patients from that area. So this is I'll talk a little bit about the anatomy first. Then a little bit about the way the cases present to me in my medico-legal practice. And then I'll talk a little bit about the NHSLA, and then about my experiences in the medico-legal field. But I'm going to start just by dealing a little bit with the anatomy and what actually happens. So if we look at the spine, this is an intact part of the spine. We've got the spinous process at the back, the transverse process coming out here, which is where all the big muscles attach on. And then coming out here is a nerve. Here's the vertebra at the front, and then the disc. So when you take the back off here, you're looking at this bit, which is the pedicle. And the pedicle joins the spine, the spinal body, to the bit at the back, to this bit, to the spinous process and the lamina at the back. This is what's called the posterior longitudinal ligament. So that separates the dura from the vertebra and from the disc. And then at the back, you've got the ligamentum flavum, so called because when you look at it, it's quite yellow, certainly in young people it is. And that joins, you can see an intact ligamentum flavum here, which joins one lamina to the next lamina. So when we're accessing the spine from the back, this is the area we would usually go in. We take away the ligamentum flavum, and then as much of the posterior structures as we need to. And what we try and leave intact is this bit, which is the facet joint, which connects one vertebra onto the next vertebra. This is what it looks like inside when you take the back off. I don't get to see this very often. This is Nick's standard approach to the spine. So here we're looking at the lower end of the spinal cord, and then this very bottom bit is called the conus medullaris. And then you can see as the nerves come out of the spinal cord, they come into this sheath of nerves, which is the Cauda Equina. So cool because it looks very much like a horse's tail. You can see that. So this is the pedicle that we cut on the previous picture. And this is a post-mortem specimen of a motorcyclist who was killed, had a head injury. And this is the vertebral body at the front. You can only see the back of that. This is the lamina at the back that I showed you just now with the spinous process. This is the ligamentum flavum, that yellow ligament. You see it is actually yellow. And then this is the spinal canal. Now these little white things are the nerves coming towards you from the head, which is out the back there. And these are cut in transverse sections, so it's as if they're wires coming down through the spinal canal. And you can see here there's a huge amount of space. So these are white things are the nerves. And actually there's more space than there is. Most of the space is empty in a normal person, and the nerves just float around in the CSF. The other interesting thing about the nerves is that when you move your leg around, they move up and down by 4 or 5 centimeters at this part of the spine, which allows you to move all your joints. And then these black things are just the blood vessels, the epidural veins. When you're operating, they can bleed quite a lot sometimes. So when you have a disc prolapse, what happens, when God designed your disc, there was a stress point at the posterolateral corner here, and you get these little radial tears. And if you look carefully on a scan, you can often see those tears. So this is the bit we've just been looking at, the spinal canal. And then this is the nerve coming out. And this bulgy bit is called the ganglion, there's a sort of connection joint there. And that's a very, very painful thing to have compressed. So with a normal disc prolapse, you get a normal disc prolapse posterolaterally. That's where most of them happen. And then it presses on this ganglion and the nerve, and it's jolly painful. And then you get sciatica. The difference between a normal disc prolapse and a cauda equina is that with a cauda equina, the disc is coming out the central area here and is massive, and then compresses all the nerves. And you'll see that in a minute. So this is what happens when you get the disc prolapse. You get this tear, and then you get the nucleus, the nuclear part of the disc, comes out through the tear, and then you can see it compressing this ganglion against the bone behind it, and it is really painful. I speak from personal experience. This is a cauda equina syndrome, and here you can see, although the disc has come out slightly more on the right side than the left side, you can see it has come out more centrally. And it's this big black blob is the disc. And so the nerves are squashed into this tiny area around here. And so that's why they don't function normally when you have these big central discs. And so you get what's called cauda equina syndrome. And you can see on this view, which is a view from the side, that at L4-5, this is L5, S1, sacrum, lowest lumbar vertebra. At L4-5, you've got a big disc and it's compressing everything at the back. So that patient may or may not have cauda equina syndrome. So you may have an MRI that looks like that. And some patients with a scan that looks like that do not have any neurological deficit because it's come on very, very slowly. But if you or I had this happen now, we would probably get cauda equina syndrome very quickly. The red flags are important things to look for. These are signs that there may be something not quite right going on. So a normal young patient with a disc prolapse will have sciatica. They may have a bit of tingling or numbness, but they won't generally have these other worrisome signs. So if you're very young or very old, that's a concern. Significant trauma, that doesn't really apply to what we're talking about today. Constant non-mechanical back pain, so that sort of horrible pain that keeps you awake all night. It doesn't matter what you do, it's a horrible pain. History of cancer, obviously, because we may be looking for patients who have secondaries in their spine. Again, this doesn't apply today. And the same with weight loss. Now, these are the other things that we get interested in. Bilateral sciatica. So if you've got unilateral sciatica, in other words, you've got sciatica in one leg, then you've probably got one of those typical lateral disc prolapses that's pressing on that ganglion. But if you've got sciatica down both legs, then it says whatever's going on is affecting both sides. So that should be an alarm bell. Weakness and numbness, as I said, you can get that unilaterally with a normal disc prolapse. But if it's bilateral, that's very concerning. And perineal numbness is probably the most concerning red flag. So if the patient says they have numbness in their perineum, they may well have numbness in their perineum, even if you don't exhibit that clinical sign. And my very last slide deals with that in a bit more detail. Difficulty with bowel function. Now, a lot of these people, because they're in such extreme pain, are on opiate drugs, morphine, tramadol, codeine, and obviously that makes you very constipated. But the problem is that if you're pressing on the nerves going to the bowel, then your bowel function may be deranged. Sorry, I put perineal numbness twice. So who gets a disc prolapse? Well, a bit like the front sheet of the meeting today, there's that picture saying who gets cauda equina syndrome, and of course everyone does. And anyone can get a disc prolapse. but it tends, the median age is 44. So it happens mostly in young adults and in middle age. It's less common in the elderly, but it does happen. And I'll show you a patient in a moment who I've just seen who's in his 60s. It's said to be equal between men and women. Those very two lowest lumbar discs are usually affected most. And it's not, you'd think, oh, well, it's removal men and people who are doing heavy gardening who get this condition. It isn't particularly. And a lot of people who do sedentary work, particularly people who drive and have a lot of vibration, have a tendency to get disc prolapse. So what happens normally with a disc prolapse? So if we have that original disc prolapse I was talking about on one side, affecting one leg, they usually have, many of them will have chronic back pain. Almost all of them will then have an episode of acute back pain. Even if they've never had any pain before, they will usually have an episode of acute back pain. And then something between 3 and 4 weeks, they then get leg pain. And when that leg pain becomes severe, often the back pain goes because what's happened is the disc has gone through the annulus and is no longer stretching the annulus. And it's the annulus in that situation that gives you the back pain. And then the disc comes out and then presses on your nerve and you get horrendous leg pain or some leg pain. But 90% of people with a disc prolapse will get better over 6 weeks. So when we talk about the symptoms, we'll start with leg pain. So this is a typical distribution of sciatica, and some of you will have had this pain going right down your leg, often into the heel or into the foot. And depending which nerve is affected, a different part of the leg and a different part of the foot will be painful and or numb. And you obviously may get weakness of the associated muscles. We see quite a lot of people who have local weakness on one side. So, for example, we may have a patient with a foot drop or a limb or some weakness and some numbness in one leg, and that is not a red flag in itself, because we see a lot of patients with that who, as I say, get better, and 90% of patients with a disc prolapse get better on their own. So what is it we're dealing with? Well, it's a rather vague collection of symptoms, and that's why people find it difficult to diagnose. So perineal numbness is very important, but you may have subjective numbness. In other words, the patient may feel numb, but you can't actually demonstrate that. They may have urinary symptoms, but urinary symptoms can be quite vague, and again, it's very difficult to pin that down. Bowel symptoms, as I said, can be very difficult, especially because these people are on opiate painkillers. And sexual symptoms, yes, they may have those, but when you're seeing someone acutely in the accident and emergency department, it's probably not the first thing you may not ask them at all. So what actually causes it? Well, it's compression of the cauda equina. But remember that we have to remember also there are a lot of other neurological conditions which can give you similar symptoms. And that's obviously the problem for the primary doctor who's trying to make a diagnosis in patients with symptoms. And what can compress it? Well, disc prolapse we're talking about mainly here. It can be spinal stenosis, and I'll show you some pictures of what I mean by that in a moment. You can get bleeding, for example, after surgery. You can get a fracture, I'll show you one in a moment, or other rare causes, tumors and things. So here's a patient. This is not a true cauda equina injury because the injury is actually at L1. This is a patient who had a fall, a young man, and you can see this vertebra is all squashed up. And this patient had, to all intents and purposes, a cauda equina lesion because his bowel and bladder was not functioning normally. His legs were functioning pretty normally, had this very slight weakness. And you can see what's happened here, that this is the vertebra, and this huge bit of vertebra has been forced into the spinal canal. This is the spinal canal. Spinal canal, the bit forced in. You can see here the bit that's come out, and that's given him neurological symptoms. So in this situation, we can treat this quite successfully, and we fixed the patient at the back, first of all, and then took the vertebra out at the front and completely decompressed that conus. You remember that very bottom bit of the spinal cord? And he made a complete recovery. So what symptoms might be present in a patient with Cauda Equina syndrome? We've mentioned a bit of this already, either reduced or absent perineal sensation, retention of urine or incontinence, or difficulty. We've talked in detail about that, so I won't go into that in any more detail. And constipation or, at worst, incontinence of bowel. But a lot of these patients don't necessarily present in that advanced state, and many of them will present with severe back pain. Now, this is the sort of back pain where they can't sit down, they can't get comfortable in any position. They often have severe sciatica, which is often bilateral. And when you examine them, they may have severe restriction of straight leg raising bilaterally. And if you see a patient with that group of symptoms, then you're probably best to get an MRI scan immediately before they do develop Cauda Equina syndrome. Of course, we need to make sure that they don't have upper motor neurone signs and that there isn't something going on higher up in the spinal cord that might make us want to do a scan of the thoracic spine. And as I said, most of them will have a degree of sciatica, but they may have weakness or numbness in their legs. And often they'll have absent reflexes, so for example, bilateral absent reflexes in the ankles, which would be unusual in a young patient with presenting like this. I know Nick's going to talk a bit more about this, but we need to differentiate between an incomplete lesion and a complete lesion. So when someone's incomplete, they have some residual sensation, they have some bladder function, they have some bowel function. And at this stage, you can usually prevent them progressing and becoming complete. So a complete lesion is a patient who has retention of urine, so they can't pass urine at all. And then if they're left, they will then have retention with overflow, so they become incontinent and have no control of their bladder. So our main aim in life is to prevent this happening. And unfortunately, far too many people at the moment are going from an incomplete lesion to a complete lesion. And that's why Nick and I seem to be seeing increasing number of patients, and it is really in our medico-legal practice, and it is very, very concerning. I think we've talked mostly about this. So here's me doing, this is rather an old slide, sciatic stretch test. So this chap hasn't got any pain. I can tell you he hasn't got any pain because he's smiling behind this block. But if I had a very limited straight leg raise and it was painful, that's a positive sciatic stretch test. And that tells you that the sciatic nerve may be compressed. And so when you're stretching it, remember I said when you move the leg around, the nerve can move 5 or 6 centimeters. And if you've got something pressing on it, the patient won't let you do that. The other thing you can do, this is checking the reflex, which is probably going to be absent. But the other thing you can do with a patient prone is to pull their leg up off the bed. And if they get pain down the front of the thigh, then that says there's a higher nerve root that's being compressed. So that's a positive femoral stretch test. X-rays are really a waste of time unless you've had an injury like that chap I showed you with the fracture. And really, the gold standard is an MRI scan. Obviously, some people can't have MRIs if they've got a pacemaker in or something like that. And most of the time, we can rely on CT alone, but sometimes we'll use a contrast agent that allows you to see the difference between the contents of the spinal canal and the soft tissues. So when do you do the MRI? Do you do it as an emergency so that they go straight in and have an emergency MRI scan? Do you do it urgently? So on the next MRI list. So if the patient's there at 6 o'clock on a Friday afternoon, that means probably Monday morning. If we do it soon, now in the private sector, soon probably means that week. In the NHS, it probably means in a month or two. Or do we do it routinely in 2 to 3 months? And I think this is where part of the problem lies, certainly within the NHS, is getting that MRI scan done in a timely fashion. So we got Cauda Equina syndrome. Should we do it within 4 hours? When I ring up our radiologist, he says, "You're going to operate tonight? You know, you're going to do it before, you've got to do it before the surgeon operates." So I say, "Well, no, I might do it at 7 o'clock tomorrow. So the chances are you're not going to do it at 6 o'clock in the morning. So maybe you do it tonight." a lot of the time, it might be at the convenience of the radiologist unless you really push him hard. So our rule in our trust now is that all people who have a question of Cauda Equina syndrome get a scan within 4 hours. So if you come into casualty, you get a scan within 4 hours. If you come into the neurosurgeons, you get a scan within 4 hours. And the same if you end up with the orthopedic surgeons. One of the problems is, and this is why the radiologists don't like us at all, that something between 75 and 80% of scans done across the country for people with Cauda Equina syndrome are negative. So I've had 2 patients in the last 3 years where I could have sworn on a pack of Bibles they had Cauda Equina syndrome. I had the anaesthetist in, I had the theatre ready, and the radiologist came in to do the scan, and I was sitting looking extremely stupid because in both those cases, the scan it wasn't normal, but they didn't have Cauda Equina syndrome. So this is part of the reason why there is so much resistance to doing emergency scans, and you just have to put your foot down and do it. I talked about spinal stenosis earlier. So some people are born with a narrow spinal canal, like this patient. So they have their canals this patient's canal is about half the size of a normal patient. And then you don't need much for disc prolapse to end up with a very, very narrow spinal canal. And it may be, if it gets a little bit bigger, that you then end up with Cauda Equina syndrome. So that's one of the reasons that some patients get it. So I'm now going to just run through where I see the problems of diagnosis and management. So obviously, most patients will start with their GP. A lot of them will end up seeing the on-call GP service, ambulance service, A&E admitting team, radiology, transfer to a specialist centre for surgery, surgical team. Most of the problems are not here. They're on the way to meet the surgeon. So what about general practitioners? Well, we heard earlier about that GP who said they'd never seen it or heard of it. On average, a GP, they reckon, will see 1 case in their career. It's quite difficult. I did 6 months as a GP. You know, you're in a dark room looking at someone on their couch in their sitting room. It's pretty difficult examining them. So there is a certain lack of knowledge, as we heard earlier. A lot of patients get sent in to casualty. They may or may not see the orthopaedic SHO or the orthopaedic registrar. They're told, you've just got back pain, go away, go and see your GP. Or they're told, well, you haven't got anything seriously wrong. And then the GP relies on the opinion of the doctors in the hospital. And then the problem is a failure to note progression. So the patient deteriorates, but they're relying on the opinion of probably what may be quite a junior doctor in hospital. So I think this is one of the areas where the problems occur. The emergency on-call services don't seem, the cases I've seen, they don't really like taking a lot of responsibility for these back pain patients. They're back pain patients for the emergency services sometimes. So sometimes they won't see the patient. They're not aware of what's happened. Again, there may be lack of experience, and they fail to refer. And again, they say, go and see your general practitioner tomorrow. And the responsibility is put back on the general practitioner. I've only had 1 case of an ambulance team who saw a patient and said, there's nothing much wrong with you, go home. And he then developed a complete lesion overnight. But that's pretty rare. A&E obviously is a big problem area, or can be. So their problem is they see huge numbers of patients, thousands and thousands of patients every year with non-specific back pain. And what they've got to do is differentiate that huge group of patients with what is a relatively unusual group of patients with Cauda Equina syndrome. Again, a lot of the doctors seeing these patients are relatively inexperienced. They maybe don't examine the patient in a lot of detail. They're very, very busy. You've heard how busy these departments are. And sometimes they won't refer on, or they won't ask their senior colleague about the problem. They don't do that MRI. And again, they refer back to see their general practitioner, and then we're back in that GP problem. Radiology. I'll show you an example in a moment. So the radiologist can see that there is severe compression of the cauda equina, and he uses this word, CSF effacement. Now, there's probably about 10 people in this room who know what that means, and probably 30 who don't. I mean, what that means is there's no CSF around the nerve, so there's severe compression. Report goes back to the GP. GP doesn't think that's terribly important. A lot of the MRI scans in our trust now are reported in Australia, Middle East, Far East, by guys online. And they really have an interest in doing an accurate report, but they don't ring me up at 5 o'clock on a Friday night and say, look, James, there's a problem here. And this is what the radiologist should be doing really with these cases, is contacting the referring clinician. And that doesn't mean just sending a report through the mail. You know, it means picking up the phone. Admitting team, this is mostly orthopaedics, which is my area. Again, there may be a lack of experience. Not asking advice is a problem I see a lot. Not doing the MRI scan. A lot of this is due to these, if you think of the hospitals in the NHS, there are probably about 30 hospitals which have out-of-hours MRI, and the majority do not have out-of-hours MRI. So the alternatives for these guys who are really not interested in backs, either they'll be hip surgeons or knee surgeons, they have no access to MRI scan. They are in a really difficult position. So sometimes they can't investigate immediately, and they should actually be referring on to another centre for patients with this condition. Sometimes people don't look at the result. That's very unusual. Failure to communicate, very unusual. They may have a patient who they're, like the patient I was talking about, who are pretty sure have a disc prolapse with cauda equina syndrome, and they have to ring round 3 or 4 different centres because there's no beds. And then often there's a delay in transfer, either because they can't get through to the centre or because there's difficulty with transport. So there's loads and loads and loads of potential delays in the system. And then the surgical team, I said there's very few problems on the whole, but sometimes there is delay in doing scans, delay in going to theatre, lack of surgical experience. I saw one case where the surgery was carried out, but clearly the disc prolapse hadn't been removed. I've seen patients who have deteriorated after surgery. So they've had an op, everything seems to have gone well. They've then started developing neurological symptoms, and that's been overlooked. And failure to, in this situation, failure to reinvestigate. I have to say this sounds terrible, but actually what one has to remember is that the vast majority of cases are treated perfectly adequately and in a perfectly timely fashion, but there are still patients who are not being treated adequately. So this is an example. This is a chap I saw on Thursday. So he's 55. He was referred on the 28th of January. He'd had 2 months of hip pain, 2 months of low back pain, and he was sent with the MRI result. Here we are. Severe spinal stenosis with effacement of the CSF, exacerbated by a right-sided disc protrusion compressing the right L4 nerve root. So that went to the GP. GP referred him into our hospital. The case was actually discussed at the MDT. He'd had a lymphoma in the past, which was one of the reasons he'd had the scan. He's await clinical review, given an appointment for the 20th of February, which is, what, in about 2 weeks' time. So I happened to see him because I was supposed to be in court, and that was cancelled, luckily. So I saw him on Thursday. He couldn't sleep. He was awake at 3 o'clock in the morning, couldn't get comfortable in any position. Severe low back pain. Pain going searing down the front and the back of his thighs. Dragging feeling in the perineum, but the perineum was actually okay. Again, I thought it was okay, and the rectal examination was normal. He had no bowel or urinary symptoms at all, but he couldn't stand up straight. His straight leg raising was, as we said, restricted bilaterally. Had a positive side stretch test. Perineal sensation was normal, blah, blah, blah. And his motor power and reflexes were normal. That's his scan. So this is the sacrum here. So that's 5145 L34. So slightly unusual. It's a level above the commonest levels. This is his spinal canal here. So that's what it should look like with the nerves, and then this big area. The white is the CSF, the cerebrospinal fluid. So you can see the nerves are just lying around with plenty of room. And then here, he's a bit narrow here anyway, because he's got wear and tear. But that big black blob is the disc prolapse, which you can see here. And then you can see his nerves are all squashed together. So this white CSF has disappeared. So clinicians, what's the management? Any offers? How would you manage this patient?
Wait till he loses his bladder, then operate.
Any other solutions? What do you tell him first?
You could give him offer him an epidural.
Okay, I have to say that wouldn't be my
Some people will
choice.
say quite dramatic shrinkage of discs.
Yeah, I think you'd be pushing it.
He's not critical, is he?
Well, I think he's critical. I think he's really critical. I think he's about to become a CES patient.
Can you just differentiate for us the prolapse from the...
Yeah, sure. So
just the base disc?
that's the disc prolapse there.
It's actually erupted out the end.
Yeah, and that's his Cauda Equina there. This is fat at the back. So that's epidural fat, Cauda Equina, and here's the disc. So the disc is occupying 2/3 of the space available in the spinal canal. Does that make any difference? I don't think that makes any difference, does it? I think it does with fractures, but not with... Well, if you're going to send him home, what would you tell him? Yeah, so you must warn him about bladder and bowel. So what I said is, if you go home, you ring the hospital. If you can't get hold of me, you go to casualty at the John Radcliffe. But how urgent is his surgery?
Very urgent.
I think it's very urgent, yeah.
He's CSI.
I think he's very urgent.
Yeah.
Maybe I'm not urgent enough. So that's what I told him, and he's having an operation tomorrow. And the only reason I didn't do it earlier was because his symptoms were not progressive in any way. So he's had them for a month at the level he has them now. But if he had progressive symptoms, I'd have had him in that day. I wouldn't have let him go home. But we can argue about whether that's correct or not afterwards. Okay, what about this one? 54-year-old female, 8 weeks of sciatica. She's had difficulty for 2 days, perineal numbness, rectal tone and sensation normal. So she's CESI, isn't she? So she's intact. There she is. Looks rather like that scan I've just shown you, but with a bigger canal and a bigger disc prolapse. How urgent is she? Tonight? Yeah, tonight, I agree. And here's another patient with, in fact, these two patients came in within a day or two of each other, identical symptoms, and yet she has got a massive spinal canal. And so you have to get the MRI, and the symptoms are often very confusing to us simple spinal surgeons. I'm sure Mr. Todd will be able to tell us more about that. And what about this one? 56-year-old male, 2 weeks of sciatica, bilateral, difficulty passing urine 2 days, perineal numbness, no rectal tone, no rectal sensation, and he's been in retention for 24 hours.
It's too late.
It's too late sometimes.
Yeah, so when do you do it? Do you do it tonight, tomorrow? He arrives now.
Tomorrow morning.
Tomorrow, any offer? Tomorrow morning, yeah. There isn't really any evidence at the moment that we should do him tonight, but there is evidence that he might recover, and he should have surgery within probably a few hours of his arrival.
Sorry, the lady before who needed urgent surgery, what if that's after midnight? Do you wait till the next morning?
Well, that's very interesting. I've had a habit of not waiting now. I had a nurse who came in, and I said, "We'll do you in the morning." And she didn't have any perineal numbness or anything. And I went to put an arrow on her in the morning, and she had already developed partial Cauda Equina syndrome. And I've seen quite a few people where that's happened. So
but the counter-argument is maybe less experienced surgeons, patients die when they have surgery.
They don't die, but they may get nerve damage, CSF leak. I think you can protect yourself in a court of law by saying, I wanted to wait and do it at 8 o'clock in the morning. I think that's probably reasonable. Personally, I mean, I just couldn't forgive myself if someone deteriorated, so I tend not to wait, which always surprises people. But I think if you waited till the end of your list the following day and the patient deteriorated, I think that would be very difficult. I just think, you know, and if someone's got progressive symptoms, then I think anyone would say, you know, they're getting worse hour by hour, you should get on and do it straight away.
I don't think, just to answer your question, John, I don't think that's right. Consultants are on call to deal with difficult cases. This surgery isn't like a lateral disc prolapse, which is usually pretty straightforward. This can be technically difficult. For a consultant just to leave this to be done badly by a junior doctor is inexcusable. I mean, that's what we're here for.
So you say do it in the middle of the night?
I'll talk about that, but I think the problem here is that patients can go from CSI, where the outcomes are broadly good, to CSR like that in an hour or 2 hours, or not for 6 months. But how do I know?
Yeah,
and the
exactly.
disaster is, as James says, to come in the following morning and find the bed wet. I mean, that's the disaster. So,
don't even recognise the difference between CSI and CSR.
well, that is true.
So for me, surgical emergency is definitely this, in the middle of the night, doesn't matter what time it is. And for me, more and more, as I become more experienced and seen problems, I think this is an emergency as well. Whereas CSR, I think you can do the next day. Now, part of the problem is why the evidence is confusing is because it's difficult to establish when it starts. It can be difficult to define, as we said, because some of the signs are very vague. You know, if you've got a bit of perineal numbness, but everything else seems all right. And a lot of the studies, as Nick will tell us later, include incomplete and complete patients all in one group. So we need to differentiate between the two. And as I said earlier, the symptoms are not always proportional to the size of the disc prolapse. So you may have someone with what seems to be a massive disc prolapse with not much symptoms, and someone with a relatively moderate-sized disc prolapse who has almost a complete lesion or a complete lesion. How am I doing time-wise, by the way?
You're a bit over, but
Am I? Oh,
reduce
God.
mine accordingly.
Well, look, I'll go through Nick's going to talk about all this. So here's a disc prolapse. This is what we do, taking the prolapse out, coming around beside the nerves, and then we take out the loose bits inside. Leave that out. So I'll just talk very briefly then about the patients my colleague Jeremy Fairbairn and I looked at. We looked at 29 medical reports. More female, and incidentally, a lot of the patients with this condition have a high BMI, so they're quite overweight. Those are the levels. So as we said, most of them are the lower 2 levels in the spine. And this was how long they had to, in this group of, these were just patients who were litigating. There were some outliers who waited weeks and weeks and weeks. So without them, these were hours to diagnosis, hours to MRI, hours to surgery, total hours wait. And with the outliers, you can see it's hugely longer. So without the outliers, they were waiting 2.5 days to have something done. And with the outliers, it went up to 7.7 days. There were 3 outliers. And this was the hours before surgery. So you can see most of them were more than 48 hours before surgery. The neurological status at presentation was perineal numbness 21, weakness 6. And we reckon that about 13 of these patients went from an incomplete lesion to a complete lesion while they were waiting to be treated. And when we looked at who was at fault, not many GPs, no, 1 physio, 2 A&E, mostly orthopaedic surgeons. And then at some of them, it wasn't anyone's fault, it had just happened. And of course, it's this group, because these are the people in the DGHs across the country who deal with all these patients who come in. So of those 29, 24 had symptoms. There was no information in 5. So they were they almost all had some moderate, 15 of 29 bowel symptoms, severe 8, urinary problems 9, had moderate, severe 15. So virtually all the patients that we had information on had bowel and bladder symptoms. And bladder symptoms seem to be worse. Thank you very much.